Good afternoon from sunny Chennai. This is Dr. Naveen again, meeting you on a very special topic. This is something that is not very usually covered in many textbooks or in seminars. This is laparoscopy in pregnancy. And this is something that's very much coming into force over the period of the last 15 to 20 years. Now, if you look at pregnancy, naturally, it has its own complications. But when you have an obstetric or a non-obstetric cause of acute abdominal pain, other than the pregnancy itself, it is a big dilemma to see whether you need to intervene surgically. And when it comes to intervention, would it require a laparotomy or whether a laparoscopy is the big controversial question. And traditionally, it has been against our principles to go ahead with laparoscopy, mainly because of the anesthesia problems, whether the problems will, the pneumoperitoneum will affect the growing fetus. All these were major concerns in the past. But recent data has shown that laparoscopy in pregnancy with a lot of careful care intraoperatively, postoperatively, can lead to a successful outcome of the pregnancy too. So moving on. So approximately 1 in 500 women will require some kind of an abdominal surgery during pregnancy, and this is, we're talking about a non-obstetrical cause. And the most common of these causes is, as we know, is acute appendicitis and acute cholecystitis. But that is not the only few conditions that you can have. Myriad number of conditions that can exist along with the pregnancy, where you can have a growing ovarian cyst with a mass, or it might be leading into torsion. You can have gallstones, which can be causing a problem, including pancreatitis. You can have adrenal tumors, which strangely grow very large during pregnancy. Splenic disorders can happen along with bleeding dyscrasias. You can have hernias which were until then undetected or detected, which can become symptomatic and might require a surgical correction. And you can have complications of IBD and other rare conditions. So earlier, it was argued that laparoscopy was not a choice in pregnancy because there was a possible fetal malperfusion due to the effects of the carbon dioxide pneumoperitoneum. The second concern was the size of the uterus and whether we had a chance of damaging the uterus because of our trocars, which we need to access the abdomen. So broadly classifying the different causes of acute abdominal pain in pregnancy, this is a very, very long list of conditions that can be present. But if you look at it, the most common still remains acute appendicitis, acute cholecystitis. It could be a UTI, which could be causing a lot of pain during the pregnancy, and it's very difficult to differentiate it from the pains of the growing fetus itself, right? And let's say if you take something like the left iliac fossa, it is usually a region where you don't have many causes for an acute abdominal pain. So when you have a patient who's pregnant and is having a left-sided lower abdominal pain, you should be very, very careful to rule out, make sure that she's not already having an ovarian cyst, which might be going in for torsion. The second thing is something known as a heterotopic pregnancy, which means that there is an intrauterine gestation as well as an extrauterine gestation, and that could be the cause for the pain. It might even lead to rupture. So never think that these things are common, but they are quite common enough to warrant some kind of a surgical management in pregnancy. So what's the difference between a normal patient and a pregnant patient? So when do we, what are the differences in making a diagnosis, and what is the difference in making the correct surgical or conservative management? Okay, so accurate knowledge of gestational age is required because we have to make correct decisions whether the fetal viability will be good, whether the fetal evaluation has to be done. Also, we have to remember that during pregnancy, you have a lot of symptoms which otherwise is uncommon or which might be more pathognomonic of some kind of a surgical problem. So these symptoms like nausea and vomiting and constipation, or an increased frequency of micturition or abdominal discomfort, these have to be differentiated. Are they a problem of the pregnancy, or is there something more sinister within this patient's abdomen? Right? So we also have to look at, these are the different changes that you would see normally in pregnancy. Okay, so if you look at the heart rate of a pregnant patient as compared to a otherwise unpregnant woman, the heart rate is increased, the blood volume is increased. So what happens is, when the blood volume is increased by 30 to 50% because of the increased flow to the fetus, you have a delay in the presentation if there is an acute hemorrhagic episode. The systemic vascular resistance is reduced by around 10 to 15%. So this results in a physiological anemia. Again, it becomes a diagnostic difficulty. The cardiac output is again raised almost by 50%. And this results normally in a lower BP in pregnant patients, right? So when you have an acute surgical condition which is superimposing, this again, you can't really rely on the classical vitals or the different parts of the cardiovascular evaluation for giving you a correct diagnosis. Another thing that you will see is there are less prominent findings as compared to an unpregnant lady. Peritoneal signs, because the uterus is occupying such a large part of the abdomen, peritoneal signs will often be absent. There will be a less muscular response or guarding to the whatever irritation is there inside the abdomen, mainly because the muscle of the anterior abdominal wall is moved away because of the gravid uterus. Also, you will find that there is a less movement of the omentum towards the site of inflammation. So normally when you see acute appendicitis and you see the omentum nicely stuck on it in a 2-day-old appendicitis, that might not happen in a similar history in a pregnant lady. Okay, so these are things that we always have to remember. Moving on to the different investigations that we like to do, pregnancy alone is known to raise the total count. And this, you have to remember, in different parts of the pregnancy, it can vary between 6,000 to 16,000. Okay, and during labor, it can shoot up to as high as 30,000. The patient is not having any other source of inflammation except the improved cardiovascular circulation, which is also increasing the raise in the total count. You also have to remember that ABG values will always be a little bit deranged during labor, so they will always be having a little bit of compensated respiratory alkalosis. So summing up that, you will have an increased WBCs. So when you have a patient who's pregnant as well as having acute appendicitis, a count of around 12,000, which otherwise in a normal patient might be significant, will not be significant in this pregnant lady. On the other hand, so you'll have a masking of the inflammation. The red blood cells also increase by around 30 to 45 to 50%. The platelets usually drop, and this is normal. There is always a bit of a physiological thrombocytopenia. The two more important things that you have to look at here are the parts of the clotting pathway, where factors 8, 9, and 10 are decreased, leading to a hypercoagulable state. On the other hand, you have an increase in fibrinogen, which leads also to a hypercoagulable state. And that is very, very important, because DVT prophylaxis is very, very important in treating a surgical condition during pregnancy. Moving on to investigations of these pregnant patients with acute surgical conditions. Ultrasound is very, very good. It's 100% safe, it's 80% sensitive, and 94% specific, especially when you are dealing with gynecological or other obstetric causes for acute abdomen, right? So these include placental abruption, ectopic pregnancy, and ovarian torsion. In a patient who's having some kind of a biliary pathology, the accuracy is very good. Again, it's above 90%. But when you're dealing with the most common cause of surgical abdomen here, the appendicitis is visualized in only around 60% of the cases. So if you look at the Society of the American Gastroenterological Surgeons, the first guideline that they say in diagnosis is ultrasound imaging is very safe, it's effective in identifying the etiology, and it should be the initial imaging test of choice with very, very strong evidence. The next thing, normally, you've been taught this over and over again, CT scans should not be done in a pregnant patient. For that matter, an X-ray abdomen should not be done for a pregnant patient. But we have had sometimes a diagnostic dilemma where a CT might be the best mode of imaging in these patients. So when you have to find a diagnosis and there is nothing else being picked up in any kind of imaging, go for a CT. So it is always reserved for emergency cases or in that rare scenario when an MRI is unavailable. So naturally, the MRI is going to be the better option in these kind of patients. So when you need to do a CT, we have to adhere to what is known as a as low as reasonably achievable principle, right? That means you give as less possible ionizing radiation. CT scan should definitely not be the initial imaging test of choice. There is very weak evidence to support that it is a good initial imaging test. It should be only used in emergency situations. So just going on a little bit more about that, this is the different types of ionizing radiations that you can get with the different types of imagings, right? If you look at what happens to the fetus, how much is the exposure to the fetus, a chest X-ray, which is the most common investigation otherwise, is as less as a 0.07 millirad. But if you look at an abdominal X-ray, naturally it's going to be higher because you're going to be focusing on the abdomen. Okay, and a CT is going to be almost 35 times that is 3.5 rads. Okay, right? So this is something that we always have to remember. Moving on, magnetic resonance imaging, preferably without IV gadolinium, can be performed in any stage of the pregnancy. So when you have a non-obstetric abdominal cause of pain, abdominal pain, where you're trying to look at the cause in a gravid patient, an MRI is preferred over a CT. But I'm going to reiterate this point, preferably do not use gadolinium. Why we don't use gadolinium is there is a theoretical possibility that gadolinium crosses the placenta and can cause teratogenesis, right? So otherwise, MRI is a very good imaging system where it shows excellent soft tissue imaging, no ionizing radiation, and hence safe in pregnant patients. Let's get to the gist of what this actual talk is about. What is the role of surgery in these patients with an acute abdomen in pregnancy? When you have a suspicion, preferably do an immediate surgical intervention because there is a well-documented data to show that the more you delay, the more chances of a generalized peritonitis, which might forget about the fetus. You are causing problems for the pregnant mother itself. So we have to remember that we want to avoid the generalized peritonitis. So we want to treat the patient as fast as possible, as surgically as possible. So when it comes to a surgical decision, whether to do a laparotomy or a laparoscopy comes into question. Now, I will be giving you reasons why laparoscopy is superior to this over the length of this talk. This is something that I want you all to see and to remember because this is data from 20 years ago. Okay, so 20 years ago, any kind of surgical intervention that was required in pregnancy, second trimester was considered to be the safest with the risk of preterm labor and delivery very, very low. And the risk of spontaneous loss of the fetus is again low. Okay, right? So this was something that was drilled into our heads over and over again. Preferably operate in the second trimester, right? So we are going to be looking at which patients can be selected for a surgical procedure, especially laparoscopy. So if you see these guidelines, as I told you earlier, are from the SAGES guidelines, right? So, and they have very, very good evidence of many patients, more than 1,800 patients, to come to these conclusions. So going on to guideline 8, laparoscopic treatment of acute abdominal disease offers equal and similar benefits to pregnancy and non-pregnancy compared to laparotomy. So what we're trying to say here is, if something that can be treated by laparoscopy, let's say just a plain and simple acute appendicitis in a 20-year-old male and a 20-year-old pregnant lady, the benefits are equal as compared to laparotomy. So laparoscopy is better than laparotomy when it comes to be something that can be tackled with laparoscopy in a non-pregnant patient. Number 2, guideline number 9. It can be safely performed during any trimester of pregnancy, but make sure that it is something that absolutely needs to be operated on. So any trimester, laparoscopy is safe, and there is very strong evidence on this. So if you look at these SAGES guidelines, the first one they produced was in 1996, the second one was in 2007, and the latest is yet to come out. It is under process. So they had a few criteria which have changed over a period of time, and this is within 11 years. So if you look at it, along with the growth of laparoscopy, you have had a growth of anesthesia, safe anesthesia. Along with that, you have had better intraoperative monitoring for the mother as well as the baby. So this is why you have had changes in the recommendations of these guidelines. So previously they used to say monitoring fetus was only intraoperatively. Now we are doing pre, intra and post-op. They said second trimester was the safest. Now it's safe to do in all 3 trimesters. Pneumoperitoneum, they said to keep it a little lower, 8 to 12 as compared to our usual 14 to 15 millimeters. Now if you look at the recommended guidelines, is treat it like a non-pregnant patient, keep it at 15 millimeters of mercury. Intra-op monitoring for the mother, we look at serial, maternal, arterial blood gas and end-tidal CO2. Here we are looking at an end-tidal CO2 of at least around 35 to 40. Previously, to enter into that pregnant abdomen, always do an open Hassan's technique. Now, the recommended guidelines is, if you are someone who does a varus, do a varus. If you are someone who does a open technique, do an open technique. So it is left up to the discretion of the surgeon. So what is happening here? In absence of access to anything else, there is a role for diagnostic laparoscopy in the workup and treatment of these acute abdominal processes. But the data says that the evidence for this is quite weak. It is not a strong recommendation. Again, I am reiterating the point. It can be safely performed in any trimester of pregnancy. Now, when you've taken up the decision to do this surgery in a pregnant patient, remember certain things help you during surgery. Number 1 would be to place the patient in a left lateral decubitus position or a partial left lateral. This basically, what it does is minimizes compression of the vena cava, and this is strong evidence. This strong evidence is also helps us to remember that normally in a second or third trimester pregnancy patient who is not having any other problem, we ask them to lie down on their left. This is to prevent an IVC compression. The same things during the surgery we are following, and we find that it is good. Also, it helps to remember that the most common causes of acute abdominal pain in pregnancy are acute appendicitis and cholecystitis, both of which are on the right side. So naturally, you would prefer the patient being on a left lateral decubitus position. Again, CO2 of insufflation of 15 millimeters of mercury can be safely used, but the evidence is a little bit weak. When it comes to a gynecological cause like an adnexal torsion and you don't have access to doing an MRI in this patient, this is an ideal case where a diagnostic laparoscopy is very, very important, and there is strong evidence to say that you can treat as well as diagnose with that laparoscopy. During the surgery, we prefer that you should not use a tocolytic, but if there are signs of preterm labor, they should be considered perioperatively, and very, very strong evidence. Number 2, intraoperative CO2 monitoring should be used in all pregnant patients undergoing laparoscopy. Good evidence for this too. Weak evidence for pneumatic compression for preventing venous thromboembolism, especially in the gravid patient. And remember, because of the size of the size of the uterus as well as the CO2 insufflation, you can have some amount of compression on the pelvic veins. So, in practice, we do like to use intraoperative pneumatic compression devices, but the evidence is not very, very strong for this. Moving on to selected conditions where you might require to know a little more details. Number 1 is acute appendicitis in pregnancy. It's the most common surgical condition and it is the most common cause for a non-obstetric surgical intervention, right? The lifetime occurrence in everybody is 7% and peak incidence is in 10 to 30%. But if you look at pregnant patients, almost 1 in 2,000 patients who are pregnant will have an appendicectomy, right? In 1991, we have data to say that out of that number of patients who had appendix removed, 1 in 1,500 had a proved appendicitis. So it is something that is definitely not an uncommon problem, okay, right? So you have to see that your examination needs to be very, very important in these patients because number 1, as I told you earlier, peritoneal signs like rebound tenderness and guarding might be absent because the appendix tends to get tucked away or pushed away by the gravid uterus. Also, tenderness, you might have to put the patient in different positions to elicit the tenderness, which will be in the right lower quadrant or even in the right lumbar region. Sometimes in 3rd trimester of pregnancy, you might find it way above in the right hypochondrial area. Rovsing sign is never elicitable in these patients and you tend to have these patients having a low grade fever. So I told you earlier, the counts, don't rely on them because in pregnancy, the normal counts can be around 6,000 to 16,000, right? But look at the polymorphonucleosides. When you have it more than 75 to 80%, you know that it is some kind of a bacterial inflammation, right? So it helps you make the diagnosis. This is a lovely picture I have borrowed from a textbook which shows you as you have the growth of the uterus, you will have different areas of the different positions of the tip of the appendix. So you will see that where it is normally supposed to be at the McBurney's point, within 3 months, it is moved up towards the right lumbar area, okay? And if you look around the 6th month, it is well into the right lumbar area and gets displaced laterally, okay? So normally 70% of the appendixes in a pregnant patient will be intraperitoneal, 30% will be in a pelvic patient, pelvic position, retroiliac or retrocolic. This pelvic one is usually seen if the patient has had some kind of a previous surgery, including a previous cesarean section. So things have tend to got stuck there. That's the reason why it tends to be still in the pelvis. So it is well noted from the way back in the 1930s that the gravid uterus displaces the appendix upwards and outwards. And as I told you earlier, because there is an increased separation of the peritoneum, there is decreased perception of pain and localization of that pain in appendicitis. Now, just show you a little video where this is a second trimester pregnancy, right? So you have, that's the gravid uterus over here, okay, right? You have a lot of omental attachments over here. They all seem to be flimsy adhesions. The ovary seems to be fine. I put in a port which is well away. So if you look at it, my camera port is all the way in the palmer's point, and I take down these omental adhesions, right? As you can see, they are all early inflammatory adhesions. So there's nothing major to worry about. You don't need to use any kind of energy source to remove this. Frequently what you will find is, because there is a displacement of all these organs, is that the ovary and the fallopian tube on the right tends to get stuck to the appendix, because the omentum does only a partial job. So here you can see that the fallopian tube is well stuck to the appendix over here, right? So just a little bit of blunt dissection and that goes away. All you have to do is to complete the appendicectomy, right? So identify the base, make sure there is no other adhesions, right? And complete the surgery. I am a fan of using silk to tie off the base before proceeding with the rest of the surgery. So that's exactly what I am doing over here. And after we tie off the base, we are safe in removing it bloodlessly after cauterizing the meso appendix, right? So it's a fairly safe procedure to be done during laparoscopy. Now this is a third trimester pregnant lady. Is one of the earliest cases where I have done laparoscopy in pregnancy. So as you can see, the gravid uterus is so large that it is not affording us any kind of view. There is only some kind of fluid collection present in the right paracolic gutter, right? I am able to see the fallopian tube here, the cecum here, but I am not able to identify the appendix. And as I told you earlier, all these tend to get stuck to each other, right? Possibly an early phlegmon. So a little bit of teasing here and there, and you will find the appendix quite safely, right? So I was able to identify the tip of the appendix, luckily, right? And as I told you, most of these tend to be within the intraperitoneal space, right? So just do the appendicectomy like you would normally do. Okay, in this case, the mesoappendix was barely minimal, so I got away by just doing an endo loop at the base of the appendix. Moving on, acute cholecystitis. This can be anywhere between 1 in 1,200 patients to 1 in 13,000 patients, right? You will find a lot of pregnant ladies having a lot of gallstones, most of whom will be asymptomatic. That doesn't make us rush into surgery in these patients. In fact, avoid them like the plague, right? They might have a history of previous episodes of acute cholecystitis, but again, that is not an indication for us to immediately rush into surgery. If they do have pain, it is always in the right upper quadrant, as you will see in non-pregnant patients. And some effect of the growing uterus is that you will have pain radiating to the back. Again, symptomatology, vomiting is very neither here or there. Because of the pregnancy, you won't be able to identify whether it is due to the gallstones per se. So vomiting is not a very reliable symptom. Fever occurs in very few instances. Direct tenderness is present, but you might have a difficulty in eliciting the Murphy's sign. I told you that appendix can move up all the way to the right hypochondrium in the third trimester, so you might have a bit of a diagnostic dilemma between cholecystitis and appendicitis, especially in the third trimester. Now, what do you do with a patient with acute cholecystitis in pregnancy? Number 1 and number 2 and number 3 will still be to treat the patient as non-operatively as possible. So we support the patient with IV fluids. You put the patient on a Ryle's tube. especially if the vomiting and the nausea is very, very significant. Put them on good pain relief and start them on a broad spectrum antibiotic, right? So the timing for surgery is very, very controversial here. Some people say that pregnancy time, it is better to finish it if the patient is really suffering, do of the surgery so that the rest of the pregnancy can proceed uneventfully. There are other people who say that they delay the surgery until 3 to 6 months after the birth of the child. The only absolute indications like how it is in normal patients will be an empyema or a gangrene, which means we have to take up the patient as soon as possible, right? So if you look at the different studies comparing conservative and surgical management, the incidence of preterm delivery in conservative management was 3.5 as compared to 6 in surgical treatment. But mortality wise, it was higher in the conservative group rather than the surgical group. Moving on to pancreatitis due to gallstones, in the conservative group, it was 8% and the surgically treated group is as lesser than 3%, which means that surgery earlier is a better option. So this is a small video which is how it is to do a laparoscopic cholecystectomy in pregnancy. This is the gravid uterus. Here you have the transverse colon. So there is some amount of displacement of the colon here, right? We are very carefully introducing our second trocar to look at the gallbladder. Here you can see that the gallbladder is quite a bad state here. Okay, there are some patches of gangrene. You need to be very, very careful because there's a very limited space for us to do this surgery. I would in fact say this is a little tougher than doing an appendicectomy because there's a very limited space. So what you're seeing here is a well distended gallbladder. It's very acute, and the first thing that I'm doing is to aspirate out all the contents as much as possible, which will help us deal with the rest of the gallbladder. So the space is a little bit increased by doing the aspiration at the beginning of the surgery. So as you can see, it's a very thick cystic duct and artery, and we have to be very careful in taking care of these patients. As I said, it's very, very rare that you might actually have to decide to do a laparoscopic cholecystectomy in pregnancy, but it tends to be a tough decision to take up, and you have to be very, very careful. So the third problem that we are going to face during pregnancy is intestinal obstruction, and this is of course going to be a little more rare compared to the other two causes, but we see that the frequency of this condition is increasing more because you have more patients who have had some kind of an intra-abdominal surgery in the past. So it rarely occurs during the first trimester, and there is an equal distribution in the second, third and the puerperial stage of the patient. So showing you a small video of how it is to deal with a case of adhesions. This is a first trimester patient who had severe acute abdominal pain and was throwing up a lot. It was not relating to the stage of the pregnancy, so an ultrasound was done which showed dilated loops of bowel, especially in the small bowel area, right? So we had gone ahead taking the risk to do a diagnostic lab. She had a previous open appendicectomy done, right? And the history was of a perforative appendicectomy. So we have to be very, very careful. We do a proper bowel walk. You see this is nicely collapsed bowel loops with the dilated loop at the back, and here you are able to identify a nice band, okay, right? So all you need to do is a division of that band and we are done with the surgery. In addition to general surgical causes for an acute abdomen, you can have other obstetric or gynecological causes for an acute abdomen in pregnancy, which might require some kind of a surgical management. most common of which will be an ovarian cyst, which has undergone a torsion. A little more rare is for a fibroid to undergo torsion. Even more rarer is for the patient to have what is known as a heterotopic pregnancy, where you have an intra as well as an extrauterine gestation, right? So this is a video where you had a patient who had a clear cyst and a dermoid cyst. You can see that there is a nice torsion over here. Okay, it's at least twisted 2 or 3 times over here. So you have to be very careful, right? So first thing I'm doing is to decompress, remove the cyst as much as possible. The gravid uterus is on the left of the screen. So after doing the cystectomy, we found that this patient is having a second cyst present over there, which turned out to be a dermoid. So that was also removed in toto. So you can see the nice hair present inside the dermoid and that fluid of the dermoid, which is very pathognomonic, right? And since the dermoid cyst is preferably removed in toto, we had to remove a portion of the excess of the cyst wall that was present previously. This is the gravid uterus here. I am removing the contents through an endo bag, which is a safe way of preventing contamination, especially when you are dealing with a dermoid cyst. So the initial ultrasound for this patient said there were 2 cysts, but it didn't fail to mention whether it could have been a dermoid. So that is the reason that we have gone ahead for removing this in an endo bag. Another case that I will be showing you is a cystic ovarian teratoma in pregnancy, right? So this is the gravid uterus again. So you have a huge cyst present over here, right? And I am proceeding to do a cystectomy in this patient. All the other same principles that we follow for laparoscopy are followed, but we tend to stay as much as away as possible from the cyst wall per se. So you are removing the complete teratoma over here, right? The problem with dealing with a teratoma as compared to other cysts may be that you might have to make a little larger incision for removing that tumor. Okay, right? So this completes the surgery. As I told you earlier, we like to remove our specimens in an endo bag. Okay, right. This is a heterotopic pregnancy, as I've told you earlier. It's both an intra and extrauterine gestation. It was picked up early by our obstetrician with the help of a sonology, and the baby, the fetus is well preserved in the uterus, but this patient had an ectopic also when we just remove the ectopic pregnancy. This happened to be on the left side, right? So the entire tube was removed, a salpingectomy was done. This was a little earlier in my career, and I apologize for the quality of the video, but these cases are very, very rare, especially when they end up being a rupture. You can have a heterotopic pregnancy which can be treated conservatively, but it's very rare for you to have a rupture of that heterotopic pregnancy, right? So in this case, we ended up doing a salpingectomy, right? So this is my talk on laparoscopy in pregnancy, and I hope you had a good time watching them. Thank you.